Okay, so today we're going to have a look at protein in urine. So we'll start with the case. So a 64-year-old man admitted with pneumonia. Depending on the week, he might have come in under Gen Med or he might have come in under respiratory. As everyone at the Austin does, he gets an A1C performed, 8%. Great. New diagnosis of diabetes. Let's start him on metformin when he's getting a bit better. Trying to be a bit more holistic, we're trying to think of the other things that could be a problem with diabetes, and we did a urinary albumin-creatinine ratio looking for protein. Came back at 18.4. So what I want to pose to you there is, how do you interpret these urinary findings, and would this change what you do with the patient? He's not on any other medications at the moment. So what I'll talk about now, so that you can try and answer this, is that, well, how does protein end up in the urine in the first place? What do those numbers mean that I've just shown you on the picture? And we'll have a brief look at the treatment, but we're not going to try and start an argument, so it's not going to be too intensive. So basically, urine shouldn't have protein in it, and it's normally less than 150 milligrams that leak through in a day. Proteinuria simply is where the dipstick level becomes positive, and you need to lose roughly half a gram of protein a day. But that number's pretty loose. It basically depends on how much urine you make and how concentrated that is, because as you can imagine, if someone makes 1 litre of urine a day and they've got some protein in it, the concentration of that's going to be very different to someone that has the same amount of protein but has 10 litres of urine. So it's not the most sensitive way to pick it up. Nephrotic range proteinuria is when you're losing 3.5 grams of protein a day. There's only 4 ways you're going to end up getting protein in the urine, and you've got to understand the nephron to look at it. So just briefly, you can have problems up the top with the glomerulus, and that's where diabetes causes most of its problems. You can have problems with glomerular disease, such as glomerulonephritis, and you can also get problems with orthostatic proteinuria and exercise proteinuria, which I'm not really going to talk about today. The next step down is you can have problems with your tubules. So if you've got proximal tubular damage or distal tubular damage from aminoglycosides or heavy metals, that's going to cause problems. And there's congenital problems such as Fanconi syndrome, which will lead to proteinuria due to this. The next mechanism is overflow, and basically that's if you jam-pack that serum with enough protein, usually from myeloma is the classic example, you'll end up getting protein leaking through to the urine. Myoglobin and free hemoglobin can do the same thing. They also can cause problems to the tubules, so it gets twofold effect. And then finally there's post-renal problems. So everything in the kidney can be working fine, but if you damage someone's urothelium, you'll end up losing protein there as well, such as a UTI. So looking for urine protein is another issue. Why should we do it? Well, we know that protein in the urine is an early marker of kidney injury, in diabetes, hypertension, and it may also be a biomarker for CVD on itself. How to do it? Well, there's quite a few ways to skin this cat. You can do a dipstick, which, as we said before, is not particularly sensitive. There's a 24-hour collection, which is the long-term gold standard, but a bit of a nuisance. And then there's these spot samples, such as a protein-creatinine ratio or the albumin-creatinine ratio. So the protein-creatinine ratio is just a really easy way to quantify the amount of protein in a urine. So the ratio of 50 milligrams in millimole is around 500 milligrams over 24 hours, so it's an easy multiplication of 10. The next thing is the albumin-creatinine ratio. So why do we need 2? Well, the albumin-creatinine ratio is really looking for a more sensitive way to pick up kidney disease, because if you wait till someone's got half a gram of protein a day coming out, you're going to miss a lot and an opportunity to intervene. So albumin in diabetes is the major protein that's leaked through the glomerulus, and microalbuminuria, so levels of protein that don't quite reach proteinuria, is 30 to 300 milligrams over 24 hours, and then proteinuria is just anything above that level. So on a spot sample, the albumin-creatinine ratio of greater than 2.5 in men and greater than 3.5 in females is indicative of microalbuminuria. And the range for that is on the spot sample is 3 to 30. So to try and put that into a 24-hour context, the albumin-creatinine ratio of 30 milligrams per millimole is the upper limit of normal for microalbuminuria, and that correlates to a protein-creatinine ratio of 50 and then a 24-hour equivalent of 500 milligrams in a day. And then the numbers don't quite linearly add up, but because once you get an albumin-creatinine ratio of 70, that's a gram of 24 hours, and it's probably about as much as we need to go into from there. So is it important? The short answer is yes. The more protein you leak, so as your dipstick becomes more and more positive, the more people end up with end-stage renal disease. So it gives us an opportunity to try and intervene. So what can you do? Well, blood pressure control is important. So we're aiming for less than 130 on 80 in most of the guidelines for people with diabetes. That comes from the College of General Practitioners and the National Heart Foundation. The other thing the National Heart Foundation has this more stringent target for people that have heavy proteinuria greater than a gram a day. The caveat to this is that we are getting more and more information that people with underlying cardiovascular disease, such as old infarcts or angina, they may get problems with diastolic blood pressure below 75 and have a higher risk of coronary events. And the Accord BP trial showed a similar cardiovascular outcome with a systolic blood pressure of 120, 135. So those goalposts might change in the future. The treatment is kind of simple. ACE inhibitors are ARBs of first line, and there's really good data that they can prevent microalbuminuria and also slow it down, but they can't completely stop it. There's also equally good data that you shouldn't use them together. So On Target is the classic older trial that used ramipril and telmisartan in about 25,000 people. And yes, it did decrease the amount of protein, but people got hypotensive, they started collapsing, they got renal problems and hyperkalemia. And it didn't quite reach statistical significance, but there was a trend toward more people dying as well. So that was thought to be a bad idea. And the VA Nephron D came out last year as well, and similar findings. So how do ACE and ARBs work? So coming back to our glomerulus over here, nice little glomerulus sitting here. It has an afferent arteriole and an efferent arteriole. Afferent arteriole under the control of prostacyclin, so NSAIDs can squeeze that down. And then the efferent arteriole is under control of angiotensin II, and that basically squeezes it shut. So the way ACE inhibitors work is by blocking angiotensin II, you end up dilating the efferent arteriole, and there's less pressure on the glomerulus, and that puts less pressure on protein to leak out. So other agents that have anti-proteinuria effects include aldosterone antagonists and non-dihydropyridine calcium channel blockers. So we're talking about verapamil and diltiazem. Unfortunately, those agents don't really have good long-term data for clinical outcomes, even though in studies they've shown that they decrease the amount of protein. And that's really we're going to stop today. So look, I've only covered a really small amount of diabetes, and we've really just looked at one small test that's done in the overall management. So obviously with diabetes, we're trying to get the A1C less than 7, but you also have to look at the cardiovascular profile, weight, cigarettes, alcohol, and physical exercise. But hopefully this sort of demystifies part of this area for you all now. Thank you.